thank you very much, everybody, for still being here this afternoon. I think it's quite right that I'm bringing up the rear, because actually out of hospital care, community hubs, probably is the enabler for all the work that we've been talking about so far that I've heard this afternoon. And also, apologies for anybody who's heard me bang the drum before, but, you know, sort of welcome to anybody who's new to this. Why are we doing out-of-hospital care? It isn't just something that we thought of as, that sounds like a good idea, although it is. There's lots of the evidence, better birth implementation, Mike West, Safe Maternity Care, all these documents do refer to out-of-hospital care and community hubs as a way to enable the continuity of care, the safe care that we've all been hearing about. Some of the principles about out-of-hospital care are community hubs. This is probably the only technical one because I think it's quite important that we take these on board. I will stand here as a registered midwife, and as a registered midwife, we're very good at working in splendid isolation of doing things on our own. I think the challenge to us is how we go out and link with our partners, with early help services, with our universal offer services, with our primary care services. So a community hub, it can be actual, it can be co-located, it can be virtual. If we get hung up on exactly what it looks like, we'll never move on. And it depends on our environment, what facilities we have in our areas, where it's based and what it happens. The size of a community hub. If we look at evidence from our general colleagues, it should be about a 30 to 50,000 population. The 5-year forward view talks about that size. Mike West, who's done a lot of work about teams working together, again says it should be that size. Black spot. Why should it be that size? Because if you're working in a population of about 30 to 50,000 people, you're likely to be working with about 100 people. If you work with 100 people, you'll roughly know who they are. You'll not be working in such a small team that you can become a bit colloquial, and I think we can all think of teams where they've got smaller and smaller and actually never developed. And it's so much easier, if you've got an idea who it is, to go and ask that daft question that's worrying you a bit about a family. So that's the rationale for why we've got to that size. And working in hubs, if you look at safe maternity care, there's been lots of documents about safe maternity care. It does help us develop those strong partnerships that keeps professionals safe and keeps our families safe. So, if we, following those principles, the community hub will encourage us to be able to access, the women be able to access a range of services, not just the one service, but that we can make a fast and effective referral when we need to. We can offer a multi-agency approach, and we can sort of develop our virtual technology. So a community hub helps all women access the services they need, with obstetric units providing care if more specialist services are required. And hubs, hospitals and other services must work together to wrap care around the woman. And community hubs should be established where maternity services, particularly antenatal and postnatal services, are provided along other family-orientated health and social services. So we know there's a well baby clinic there. We know there's an early help offer clinic there. We know there's breastfeeding clinics there. The perinatal mental health support groups, so that we can make easy referrals for those women who may be needing a little bit more help. So what does a community hub look like? Midwives, GPs and primary care services, health visitors, parent groups and voluntary organisations, and our early years. I think they're the core that we should start thinking about in some of the community hubs that we're setting up on the Falcos, I've got the neonatal outreach team saying I want to be there as well. And again, that is helping to link in with your perinatal mental health, your infant feeding, starting to learn about your universal services, so that women don't just fall off a cliff, that they are starting to link into the other services that are there to help and protect our families. So while we've been talking about this and while we talk about working together, working with other organisations, it's important that we keep our families safe. And whenever you read a serious case review, how we make links and how we transfer care between professionals often comes up as an area that could have been strengthened. So if you go back to Midwifery 2020, which was published in 2010, they start talking about the coordinator of care. And the midwife will always be the coordinator of care during pregnancy and up to 10, 14 days postnatal. The lead professional may be the midwife, maybe an obstetrician, maybe another specialist, depending on where that woman is in her journey, what's happening to her. But it's really important that we clarify who's the care coordinator and who is the lead professional. So the principles are that a midwife or a small team of midwives will provide the majority of care for that woman, facilitating a holistic care in a collaborative system. If we do that, we've got our continuity of carer. So this is how all the things must work together. And midwives are the champions of maternity care and in all care settings, and will transfer that coordinator of care at the right time to the health visitor, who will then become her coordinator of care onwards with the baby. So bearing in mind, as midwives, we understand low risk and we understand those thresholds. When we were working with early years staff and our universal staff, it's making sure that that we got a universal type language, that we're not using secretive language. So women who have straightforward pregnancies will have that core universal offer. We will offer antenatal care, screening, public health messages such as stop smoking, vaccination, immunisation. Wouldn't it be fantastic if our community hub had a pharmacy on site and you just said, just go down the road to get your flu and your pertussis vaccination. Healthy eating. That's been added on since the last presentation in Morecambe Bay. And postnatal care. If a woman is requiring a little bit more support, we'll be offering Core Universal Plus, maybe linking in with CAFs, more things. And Partnership Plus is when we're having to bring in more professionals to help with that care. But midwives will always be the coordinator of care, and the lead professional may change depending on that woman's care. Specialist care may be for if a woman is, say, needing tertiary referral, fetal medicine, cardiac support. And at the heart of all our care, we must never forget what our principles are. And the community hubs will enable us to do this, to focus on the leadership, to learn from best practice, and that may not be within your maternity, your children's services. We can all think of other areas that have good practice. We can develop capabilities and skills in our teams. We can then use the data to inform our practice. My ideal goal would be we get data for our community hub so we know exactly what it's like working in our community hub, what extra services we need to bring in. Do we need substance misuse in that service? Do we need more mental health support in that service? So that we can be really innovative to maintain safety, which has to be the golden thread going through here, and we can safeguard our families. That's it. Oh, so what I've said, and there it is, a plan on a page. All that presentation is included here so that we can share it. Thank you, Julia, for that. That's it. Thank you.
Okay, thank you, Pauline.